Hello, it is my great pleasure to welcome everyone to tonight's webinar. My name is Rajat Chand, and along with Maggie Chung, I serve as the current co-chair for the SIR-RFS Communications Committee. On behalf of the Society of Interventional Radiology Resident Fellow and Student Section, thank you for taking time out of your night to be here for this very informative webinar. Before we hand it over to our main moderator for tonight, I want to remind everyone that this webinar will be recorded and will be available on YouTube in the coming days by searching IR Education. Anyone is free to ask questions at any time throughout the webinar, simply by entering them into the question box on your GoToWebinar control panel. We will keep track of them and answer them at the end. Also, please check the RFS website regularly for upcoming events, and follow us on Twitter and Facebook for other updates and posting of clinical IR educational material. I will now hand it over to Hector Bunch.
Hello everyone. Thank you for attending our webinar, IR Residency Applications Program Director Perspective, brought to you by the Society of Interventional Radiologists, Medical Student Council, Education and Research Committee. My name is Hector Bunch. I'm a fourth-year medical student at Ponce Health Science University School of Medicine in Puerto Rico.
Hi everyone, my name is Kathleen Copel. I'm also a fourth year at Ponce Health Sciences University in Puerto Rico. I will be co-hosting this webinar with Hector.
As many of you all know, application season is on us, and it can be a very stress-inducing time. We are incredibly fortunate tonight to have 3 program directors take time out of their busy schedules to speak to us and to shed some life-saving advice about the application process and how to be a competitive IR applicant. So this will be our agenda for the night. We're going to have Program Director panel introductions, a brief summary of the training pathways, frequently asked questions for the panel, including questions regarding applicant competitiveness, about away rotations, about what students should look for in a program, about intern year, and about the couples match. And then we will have audience-submitted questions for the panel.
So we have a couple of ground rules for the evening. Firstly, we will mute everyone but the panelists' mics throughout the webinar to minimize background noise. So please type into the chat box if you have any questions. And you can direct these questions to Hector. We'll go over that a little bit more at the end, but from the chat box drop-down menu, you can do that, and we will announce your questions to the panelists. Secondly, everything that is discussed during the webinar will be recorded. If there's any part of the webinar that is inappropriate or irrelevant to the discussion, it will be removed from the webinar before it is publicly posted. And again, just please send any questions directly to Hector by selecting his name. This is really important during the Q&A session at the end. We'll read and announce your questions to the panelists, and all of your questions and comments will remain anonymous. So we just ask that you guys please refrain from asking questions at the beginning, since those questions may be covered during the first part of the webinar. And thank you guys so much for your cooperation. So now we're going to get started by introducing our panelists. We're so grateful and so happy to have all of them with us tonight. We're going to start with Dr. Christopher Ingraham. Dr. Ingraham, if you could just tell us in like 30 seconds a little bit about yourself, your background, and what your interests are, that would be wonderful.
Great. And can you hear me okay? Just checking the sound check here.
Yeah, we can.
Okay, great. So I'm the program director out at UW in Seattle. I'll just say quickly, I actually started in surgery, so I'm somebody that transferred programs, which is important for helping to mentor people find out where they want to be within medicine. And it leads me to, which we'll discuss, is if you're unsure about IR, if you like it but you're unsure, there are some options available for you. But I started in surgery out at UW, and I transferred after 2 years into radiology. That's all that was available then, right before the IR residency. And then I did my IR fellowship here, which I completed 4 years ago. So I've been an attending out here 4 years. I've been helping with the programs since the day I started, and I took over program director about 2.5 years ago. So as you'll meet the other panelists, most of us have built the programs from the ground up, so we're very familiar with it, but it's relatively new to us as well. So happy to be here. Thanks for inviting me.
Well, thanks to you for coming and welcome. Next we have Dr. Joshua Cuban. Could you please take just about 30 seconds to introduce yourself, Dr. Cuban?
Sure. My name is Joshua Cuban. I'm on staff at MD Anderson Cancer Center, UT MD Anderson, and I'm actually the Associate Program Director. Dr. McCrae, one of my colleagues, is the Program Director. I did my training at Boston University as an undergrad for medical school, and then did a year of surgery at Brigham, Baylor, and then Brown for IR, and then I joined the staff at MD Anderson 2 years ago and started as the Associate Program Director at that time and did the IR-DR program and ESIR, and working closely with Dr. McCrae, getting more and more involved each year.
Thank you. Welcome.
Okay, Dr. Paul Rochon, could you do the same? Give us your 30-second spiel.
Absolutely. Thank you very much. First and foremost, I wanted just to thank the Medical Student Council, the Education Research Committee for putting this very important webinar on. My name is Dr. Paul Rochon. I actually am from Louisiana. I did medical school at LSU in New Orleans. Around this time of the year, about 12 years ago, I was displaced from my residency at LSU and finished my residency at University Hospitals Case Western in Cleveland, and then ultimately I did my fellowship at Miami Cardiac and Vascular Institute. I've been on staff at the University of Colorado School of Medicine for about 7 years now. I have been the program director for the fellowship program for the past 5 years, and I am the program director for the integrated pathway for the IR residency. We have 2 slots for integrated pathway, and we have applied for our ESIR as well as an application process for our independent pathway. This is a very exciting time for all of the programs, and we hope that we can answer as many questions as we can this evening.
Great. Well, it's a real pleasure and honor to have you with us. We have one more attending who has been unable to make it so far. He might be joining us later. This is Dr. Jonas Redmond. So if you guys hear someone new come on a little bit later, this is who will be chatting with us.
Right, so before we get on to talking about the training pathways, I just wanted to make it clear to the audience that while completing an IR residency will certainly allow you to have certification in both DR and IR, the IR training programs are not IR/DR training programs. We call them IR programs, and we call the residents IR residents. So Dr. Rochon, will you please explain to us how the training pathways work, since we all know that there are IRs in a state of transition, and having recently become a new specialty with the direct pathways, it's a growing field, and there are many pathways that we can take to become an interventional radiologist.
Thank you, Hector. I just wanted to say that I try not to use the word direct pathway, because that's an old pathway that residents could actually get training through IR. So I will just want to use IR residency and the different types of pathways and programs for the residency. So most of us are familiar with the integrated IR residency. It's basically how you get into IR out of directly from medical school. It comprises a 1-year internship followed by 5 years of residency. Within that residency, you will do 3 years of diagnostic radiology and 2 years of IR and IR-related rotations, and that's in your PGY 5 and PGY 6 year. Now, your IR-related rotations will differ from institutions, but commonly they may be vascular surgery, for instance, cardiology, medical surgical oncology, transplant surgery. All institutions have the freedom to create what relationships and programs rotations that they have in their institutions right now to benefit and enhance their residency. there needs to be at least 1 month of ICU experience, and typically that is in the PGY 5-year. And that's pretty much the integrated IR residency. It's a really competitive process right now because it's brand new, and we hope to shed some light on some of the questions that we'll be getting from you guys later. The second program is the independent IR residency, and it's similar to our fellowship program as well. The last fellowship program will end June 30th, 2020, and that's when the new independent residencies will begin in July of 2020. It's actually designed for those residents and students who pursue IR later in their residency. And I know that a lot of medical students will maybe decide early on that you want to do IR, and you may be applying to both IR integrated pathways and diagnostic pathways. So there is a process or program that you can get into through diagnostics, and that is the independent IR residency. Now, this residency is actually 2 years. So you will complete your diagnostic radiology residency, and you have a PGY 6 and PGY 7 year. And that will actually happen. You'll be interviewing for these this program in your PGY 3-year of diagnostic residency. Third pathway or program is the early specialization in interventional radiology. A lot of medical students are asking about this institution to institution, and it is a program that is in the diagnostic radiology residency. It requires at least 8 IR rotations, 1 ICU rotation, and up to 3 IR-related rotations through your PGY2 to PGY 5-year. Now, most of these rotations will be in your last year of residency. It also requires at least 500 IR or IR-related procedures. Now, diagnostic programs will sign you off before you actually get into your independent residency. You still will need to apply for an independent residency. What the ESIR program will do, it will allow you to only take 1 year of the independent residency. So you'll be able to take off the PGY 7-year and finish off your IR residency in your PGY 6-year. It's very attractive to those who are interested in IR. However, I just want to make it known to all medical students that the reason why these different programs were developed was to allow as many opportunities for you to actually get into IR. So we want you to take advantage of this. We understand it's a very competitive process, but there are all these opportunities, and more programs are actually becoming accredited, especially the independent IR residencies at this time.
Wonderful. Thank you, Dr. Rochon. And first of all, am I pronouncing your last name correctly?
Rochon, yes. Thank you.
Rochon. Okay. Perfect. So that was an excellent summary. For any of the students who are listening who are wishing that, oh, maybe we could have this all summarized neatly for us, SIR recently published a chapter about being a competitive applicant in interventional radiology. This is all detailed there, and we have a link at the end of this presentation that you guys can use to find that chapter. So now we're going to start the Q&A portion of this webinar. We have a series of questions which we believe will provide grounds for some continuing discussion, answer commonly asked questions. So we have questions particular for our program directors, and we're going to do kind of a rotating format for you guys answering. So we'll start with our first question with Dr. Ingraham answering first, then Dr. Cuban, then Dr. Rochon, and then the second question we'll have Dr. Cuban answering first, then Dr. Rochon, then Dr. Ingraham. And program directors, you don't have to worry about that. We'll cue you guys for whose turn it is to answer, but that way we'll keep a little bit of diversity in who's answering first and who's answering last. So we'll go ahead and get started.
All right. So for our first set of questions are regarding applicant competitiveness for these programs. And our first question for Dr. Ingraham will be, what makes an applicant a competitive candidate for IR training?
So good question, a generic question, but a good one. So what I would say is what makes you competitive, or I would even say qualified, is that you've at the very least done 1 month of IR. Now I want to make sure that you know what you're getting into, that it's a good fit for you, you've seen it, and you have someone that can vouch for you. So meaning an attending who could sort of serve as your mentor. I realize it's sometimes hard to find a good mentor in life, but you know, that you've identified at least one faculty member that's discussed IR with you, can write you a good letter of recommendation, and from there you could do even more. So at least one rotation at your home institution. I realize that can be difficult for some applicants and sub-Is that I've met where their home institution might not be strong, and in that case I recommend you do an away rotation. I don't think that that's required, but you know, it just gives you more opportunity to see what IR is about, and also see what different programs are. A lot of times candidates have their hearts set on being in one place, which I think is fine, and it certainly helps to do an away rotation if there's a certain institution you'd prefer to be at, because those attendings in that program can see how you are. So I would say at least 1 month of IR, preferably 2 if you can do it. An away rotation is great. I actually think it's a really good idea for candidates to do a rotation in diagnostic radiology as well. Remember, that's 3 of your 5 years you're going to spend in DR, and more importantly, you have to be very good at radiology to be a good interventionalist. So if you can do it, if you can manage it, I would recommend a rotation in DR as well. And for someone to be competitive, people always ask me about board scores. We can get to that later. I really don't find that makes you a good physician. Obviously, you have to pass your boards, and you have to pass your boards in radiology. We don't really use the cutoff that UW. Some institutions do, though, and you should be aware of that. So, you know, what makes you competitive? If you're 220, 230 or above, I think nobody will really talk about your score. If you're below that, that doesn't mean you cannot match into IR. It just might make it difficult in some places to care about that. Board scores, they matter, but not very much to me. What I care more about are your clinical grades. How good did you do? How well did you do in surgery, medicine, family practice, OB, psych, peds, basically your core rotations, particularly medicine and surgery. I love to see honors or A's if you guys get grades at your home institutions. A lot of places don't. That doesn't count against you. So I care a lot about how you did clinically. AOA or Gold Humanism, it's great if you have that, not required. It's basically just another plus on your application. And then I looked lastly to see that the applicant is well-rounded, so that doesn't mean that you've done 10 research projects or you have a PhD and it's all IR-related research. If you've done research, great, not a requirement in my book. I only care that you know the project and you had some sort of longitudinal involvement in the project, not just helping 1 week or 1 month and you were out. So if you did research, make sure that you understand it and you were committed, and I don't care if it's an IR or not. And if you don't do research, I just hope that you're involved in activities, whether it's volunteering, service, even if it was an interest group in a different field, basically that you've been involved to make your med school a better place. We'll probably talk about letters later, but just briefly, I really like at least 1 IR letter, preferably 2. And having one from radiology or surgery also helps. So I know that's a long-winded answer, but it's kind of 5 or 6 points that I look at whether I'm going to say, yes, I'll interview this person.
Okay, thank you very much. So now, Dr. Rochon, Dr. Cuban, if you could please tell us what you look for in a competitive candidate for IR.
Sure, and just for everyone, it's Cuban, like the cigar with a K.
Got it.
All right, so I would, what Chris said, I would also echo for scores. USMLE scores at a certain level won't hurt you, but after that, they're really not going to be the biggest thing we look at. Clinical grades being extremely important. For me, as much IR-related experience is really important for me. I'm looking for involvement in RFS. I do think IR-related research, if you can, publishing something, at least something that shows like a full package of interest in interventional radiology, that you've been exposed to the field and you're still very excited about it. I like to see as many months in IR as possible. I know that's sometimes not possible for everybody, but I feel more comfortable that someone really wants to go in IR if they've spent as much time as possible in the suites, in the clinic, and know what they're getting into. So that's another big plus for me. The biggest thing I'm looking for really is someone that's pretty passionate about IR. I think passion is a pretty hard thing to find in an application. Easy thing to find in an interview, but it's a challenge to try and find those people on paper. So looking for ability to overcome adversity, handle stress, and a lot of that echoes in your clinical scores in surgery and in medicine, being able to handle those rotation wells and do well. And obviously someone that's very personable. We're going to be working together closely over a long period of time, so looking for someone that's good to talk to, is looks like they can handle interpersonal skills pretty well, and that are very passionate about interventional radiology.
Great, thank you. Dr. Shona, if you please.
Yes, thanks, Hector. I echo what both Josh and Chris said. I would like just to add, I know a lot of medical students are focused on the step 1 and step 2 score. I mean, that's a way that all programs can put everyone on a level playing field. And the only thing I can say is, just as other specialties, other residencies are competitive and they're looking at different board scores, or maybe not even, just do the best that you can. For those of you who are MS1s or MS2s, you know that you need to do well. Set out the time to study for your step 1 and do the best that you can, and have no regrets as you move forward. And then you get into your clinical years, and as Dr. Ingraham said, you want to make sure that you do really well in those core rotations, because those are going to be the programs or the letters that you're going to be asking for. We don't expect all radiology or all IR letters of recommendations. We will appreciate others, and those are going to be letters of recs that you're going to ask of those who can actually write you a great letter, an excellent letter, that you have excelled in that rotation, and those recommenders will know you really well, and they will support you in your progression to an IR residency. It's the whole application that we're looking at. We want to make sure you're well-rounded. You have passion in IR. You are seeking out the IR resources that you have at your institution, and all of those will be different depending on where you are in medical school. There are a lot of resources on the local level, the regional level, and the national level. There are a lot of resources in the medical student councils and resident and fellow section that you can actually take advantage of. IR symposia, things that you can definitely get involved in. These are different ways that you can do it, and there are different projects. I mean, research, that's a question that we're going to probably have later. It's important if you have the passion for it. I mean, it's not a requirement, but it may set you apart from someone else. And think about those things that you're going to have in an application. You want to make yourself different from the next, from your competitor. But you also want to make sure that you're a team player, as Dr. Cuban said. You want to make sure that you can work long hours in a stressful environment. How do you deal on the stress? And not that the IR residency is stressful, but you will be put into stressful situations, and the types of patients you're going to care for, the level of acuity that you're going to be caring for patients. So those are things that we're looking for in candidates, and candidates who want to grow and learn every day through IR.
Great, thank you all. Those answers make a lot of sense, and they're super helpful. We're going to go ahead and skip the next question, since you all answered that a little bit in your responses. And we'll go to what kind of extracurricular activities are important. You guys touched on that a little bit, but we'll just circle back for anything that you want to add, starting with Dr. Cuban.
So for the extracurricular activities, volunteering is great, and having some of that being well-rounded. I am always looking for something that fits in a story of an applicant, whether they had an extracurricular activity or research in ortho, and now all of a sudden it's in IR. Kind of want to see what that story is of why you transition from one to the other. As much as you can do with interventional radiology, to me, speaks to kind of a passion and an overall sense of direction that you're going to need to get through diagnostic radiology to IR. So IR-related research is important. Any research is good, but if you can, again, just have something on there, it doesn't have to be groundbreaking. Involvement with the RFS, I think as a medical student, it's a free membership. It's something we did when I was back in the RFS. I would look very, it would be a huge detractor for me if someone that can be a free member of the Society of Interventional Radiology is not a member. So I think that's almost a necessary thing at this point. And then as much as you can be involved in the resident fellow section or the medical student section, just again, your dedication to interventional radiology and something that will carry you through what will be hard years in internship in diagnostic radiology, because you have this passion, you have to have it fueled, and it's a challenge during that period for a lot of programs before you can kind of get into interventional radiology. So we're looking for people that are very motivated, and those extracurricular activities help with that. If you're also into something that's interesting, like you traveled or you did volunteer work in the country, those all add to your application. Passionate person or ability to overcome adversity or challenging circumstances. I don't think those are obviously necessary, but they definitely don't hurt your application. But for me, the biggest thing I'm looking for is a story, a coherent story of how you got into IR and what drives you, and is that drive going to be strong enough to keep you going?
Wonderful, thank you. Dr. Rochon.
Yes, that's a really great question, and it spans the activities from research to hiking or doing something that you're really passionate about. And those things are not required, as Dr. Cuban said. However, it's really important as a medical student for you to be balanced, and we know that you don't have a lot of time throughout your medical education. We want you to concentrate on your exams and your rotations, and definitely excel in those. And if it takes time out into your studies, then you know what, you may not want to do that many extra curricular activities. But if you can, and you want to make sure that you're passionate about those, I echo with trying to do as much IR-related things as possible, but also do things that you're passionate about, that you can talk about in an interview. You're going to list it on your application, but if you can't really talk about it, then it's going to come through in your interview as well. If you like to read, let's talk about, what was your last book that you read, and let's talk about that. And we want to see that passion in whatever you do, and that passion actually needs to be transferred to your IR residency, because you're going to be spending a lot of time in diagnostic radiology and IR. We are a family, and we're going to be seeing a lot of each other throughout your rotations. So we want to see that passion that you have given into your put into your extracurricular activities translate to IR. And as Dr. Cuban said, we want that story, we want that complete story. And if there any anything that's discontinuous, then we're going to see that. We want to make sure that you have passion in whatever you do, and it doesn't matter what it is, but as long as you can actually talk about it through your interview.
Makes a lot of sense. Thank you. Dr. Ingraham.
Yeah, my panelists kind of touched on everything I would add is that you're well-rounded and that you contributed something to it. My former chairman used to say, how did you leave your ex last place better? What did you make better at your home institution? Whether that was setting up a volunteer program, whether you were involved in student council, whether you were very involved in setting up the first IR interest group or radiology interest group, or you're active in that and mentoring other people. You don't have to be president of it to get my attention. You just have to show passion about it. And whether you're a marathon runner or you like to sail out in the ocean, I mean, I love hearing about those things, and it shows dedication when you know it well and you've been committed to it. So please don't feel like you need to list every activity that you've done, even if you went to just one meeting, because to me that shows you're just putting it on there and you really weren't committed to it. And just to touch on research, everybody always asks about it, but like I mentioned, and my other panelists have mentioned, it's great if you have IR research and you get involved early, but maybe you made your decision in your MS3 year to do IR, so maybe you don't have time to have done a full project. And it's fine to list a few projects if you've been involved in it, but make sure you know them well and you didn't just help out for 1 week and you're listing it there, because we will ask you about it. I'd rather hear about you did basic science research between your first and second years, and if you loved the project and you learned, you would rather never do lab work again. So that says a lot more to me than just being involved with projects you really aren't helping. So if you have the time to do IR research, fantastic. I think it only helps you and in fact makes you very strong. But please don't feel like now all of a sudden you've got to get involved in a project before you submit your application.
Okay.
Thank you very much. That makes a lot of sense. So we're going to start our next round of questions with Dr. Rochon. The next question is, do you have any advice for DO and IMG applicants?
I do. Just apply. And I say that knowing that the application process is competitive across the board. But one thing I would give to the DO and IMG applicants, there are resources through RFS that you can actually get involved in. I want to reemphasize that. Become a member of SIR. That will let us know that you are interested in IR as well, or just look at your application. Create an IR interest group if you don't have one at your institution. It may start off small, but it'll start off with you and maybe a handful of other medical students, and that can actually move on to becoming involved in a regional symposia, in medical student symposia. So really engage yourself there. You may not have a lot of resources, but you can gather those resources through the national organization. Reach out to other neighboring institutions that may collaborate with interest groups and or medical student symposia. But really be involved in SIR. I think that's how DO and IMG applicants can really set themselves apart and become really competitive.
Thank you, Dr. Rochon. Moving on now to Dr. Ingraham.
Yeah, I echo that. I would say, you know, two of my best prior fellows were DOs. So I think that, you know, nationally you may have a little bit more trouble compared to an MD applicant just because some people have a chip on their shoulder about DO or IMGs. But getting involved early, finding a good mentor, being involved with SIR, and, you know, do some away rotations. That's your chance to audition and show that you have what it takes. So, you know, similar to other applicants. I mean, like I said, my fellow last year who was a DO was absolutely phenomenal and outshined some of the other fellows, and it really just took, you know, a little extra work improving that. And I would say that I really have nothing against DOs or IMGs. It's just you might have to do a little bit more and start early and find a good mentor.
Great, thank you so much. Dr. Cuban?
I would pretty much say the same thing. I would say apply very widely. I think networking is extremely important for everybody, but most is going to be the most important for DO and IMGs. Find out where people in your school have gone before you. Reach out to those people. Try and get options that they've been successful at. Your best credibility, because a lot of times we won't know the schools, not as much for DOs, we kind of know where they are, but for IMGs we don't have a good idea of the product necessarily that comes out of that school, but we know people. So if you know someone that's been there and you can introduce them and say, oh wow, I know this guy that went to the same place, he's great, now I'm sure we're going to get something similar from this person. So try to network as much as you can with people that are coming from your institution. It would be something very important. I would also say, at least for DOs, that I found a very different approach, or in the north versus the south. I did most of my training in the north, where I feel like there's not as many, not that way in the south. So if you haven't applied, or you're a DO and you want to stay in a certain area of the country, apply a little bit more broadly than you would have otherwise. And at least for me, in my experience, the south is a little more welcoming than the north has been.
Thank you very much.
Okay, so moving on to our next set of questions. This is about away rotations, visiting rotations. Starting with Dr. Ingraham, what is your opinion on away rotations at your institution, and how many of these should an applicant complete?
So good question. I think I touched on this a little bit. I think it actually helps. We have 3 IR residency positions, and 2 out of 3 were outside applicants that rotated with us. So I think it just gives us a really good opportunity to work with you, and it's a little less of a gamble, right? Because we're going by things that are on paper, what people say about you, and that you're great, but working with you firsthand is really the best way to get to know you. Now, I don't think that it's required. I certainly do not require it, but I think it can only help you. So, like I said, if you have your heart set on going to one place, it's a really good idea, or even if you can do 2 away rotations, I think that's great. And then just know that, you know, if you decide to do an away rotation at Michigan and the rest of us see that, we think, okay, maybe he or she's got their heart set on going to Michigan. So it will sort of categorize you, not in a bad way, but how this person probably wants to be at that institution. So again, I don't think it's required, but I definitely think it helps, and especially if you, for geographic reasons, need to be in a certain city because of your significant other or family, it can help you, but it also doesn't guarantee you a spot there.
Okay, great. Dr. Cuban.
So I would say do as many IR rotations in general as possible. And then in terms of away rotations, I think of them positively in terms of networking. It does show that you want to go potentially different places, but not always, and especially if you kind of talk about that and address it in your interview or your letter. To me, doing a bunch of IR rotations again speaks to that core passion in interventional radiology, where you could have stayed home and done, entrepreneurship in medicine or something, or something else that was easier, and you decided to do, take the time, fly somewhere, live in a new city, take a risk, handle the stress, and go into a department and kind of give it all you have. That speaks to me. I like that personally. However, you have to really shine when you go there, because when you're interviewing, yeah, you're kind of in the crowd. But you have that interview, you could do really well for the 20 minutes, but when you're with us for a month, any deficiencies are going to come out. So you really, when you come there, you got to work really hard. You don't have to know everything, but you have to be, be the first one there, the last one to leave, really be the hardest working person there, and then it's a good way to shine to that program and focus on places you want to go, or it's also a good way to get a great letter. Sometimes I'll look at an application, I'll see a letter from a buddy of mine from these other big programs, like, oh, I know them, and he's like, hey, this was a great medical student rotator, and that's something that I know is a quality recommendation because I know this person, and they rotated with them, and it might help you in terms of your networking. If you can go somewhere, give a great performance, and get a letter, it may transcend the actual place that you go.
Great, perfect. And Dr. Rochon.
Thank you. To add to that, I do agree that rotations are great. You should do as many as you possibly can within your institution, what your institution will allow. You want to try and do those before interview season. And as Dr. Cuban said, you want to shine. This is going to be a main part of your interview. Some institutions may want to invite you back because they know you for the interview. You are going to be networking. So you want to do really well. You want to read. You want to make sure that you know everything about your patient. I mean, getting down to the nitty-gritty. And the reason why I said you want to be careful of the rotations that you do during interview season, you guys are going to be preoccupied with figuring out, coordinating interviews, responding to emails, and it's going to be hard not to stay attached to your computer. And we want you to be present during your rotation. And not just stuck to checking emails constantly throughout the day. We want to be sure that you're working, peri-procedural management, working with our residents, working with our fellows, or fellows at this time. How many of you should complete? As many as you can. And as my fellow panelists alluded to, use that opportunity to try and do a rotation where you may want to get an interview, where you may want to do your residency. You may find out that you may not be happy in that program from rotating with them. And for those of you who may want to stay at your home institution, do an away rotation to maybe compare to your rotation, to your institution, to see what other things there are in IR, because every institution is different.
All right, thank you very much. Moving on to the next question, we are going to start with Dr. Cuban. In your opinion, what should students look for in an IR program?
It's a great question, and there's going to be a lot of topics here, but I would say the most important thing is a personal fit and a passion. There's a large gap between.
I'm sorry, Dr. Cuban, we're losing you a little bit there.
Can you hear me now?
Yeah.
Okay. So there's going to be a large gap between when you match and when you actually start doing IR in the department. And there's going to be a lot of things that will change over that time. It's guaranteed. things will change with regulations, people will leave, people will come. The most important thing is that if you have a program director and faculty that are very dedicated to the training program, very passionate about improving the training program, then you know that whatever changes will happen are only going to be for the positive. I think that a personal fit also shows that when you rotate, are people getting along? Does it seem like a good atmosphere, a fun atmosphere? You're going to spend a lot of time there, a lot of hours, and so kind of a personal feeling that you get from the people around, the environment, whether you could be comfortable and happy in that environment. That also includes geography, which is a whole other topic. I think case mix and autonomy is very important, flexibility of the program director, and then durability also of the program. Are they well resourced? Is it a program that may lose accreditation? Is it going to potentially lose funding for any? These are hard things to know as an applicant, but you can get an idea about the strength of a program when you go there with the resources they have. This is all in addition to, the cases. Make sure that you have great teachers that are you're seeing all the different variety that you need to see, and that you have people that are very passionate about making sure that you get the education you need.
Thank you. Moving now to Dr. Rochon.
I'm going to talk a little bit more about the DR aspect of the IR residency. Yes, you're going to be looking for the fit of the IR program, the differences and what makes those IR programs stand out, and the mentorship that you're going to get from those programs. But you need not forget about the DR aspect. Typically, you're going to get at least 3 years of DR education. And as was alluded to before, the stronger you are as a DR, a diagnostic radiologist, the stronger you are going to be as an IR, an interventional radiologist. So you should be asking questions about resources and educational opportunities as a diagnostic radiology resident, because you are going to need to be reading just as much as your diagnostic radiology colleagues, making sure that you are prepared for your boards, because you will have less rotations than most of your DR residents, but you will have enough, but you will have to work a little bit harder to make sure that you're excelling on your rotations. So really look into the DR aspect whenever you're interviewing for your IR residency.
All right, thank you. Moving on now to Dr. Ingraham.
Yeah, really good comments by my fellow panelists. I think the most important thing is it's a good fit for you. It's like dating. It's like a relationship. Make sure it's going to work, because it's 5 years, and most people end up where they need to be and where they want to be in some way, with some rare outliers. But for example, all the panelists here were part of busy programs, big programs. I don't think that's for everyone. If you're somebody that likes the idea of a community program and everything being fine, I think that's fantastic for some trainees. They don't like the idea of an overwhelming program with multiple sites and multiple residents and everything's kind of crazy. So make sure that works for you. And when you're on your interview day or doing a sub IR, you see that the residents are happy that they're interacting with the faculty. Make sure that the DR program is strong. You're spending more than half of your time with the diagnostic radiologist. So you want that to have a good foundation in IR, and half of my folks have gone on to take jobs where they're doing some diagnostic radiology. So you want that training. It's not like being in surgery. DR is fundamental to what we do. So make sure that you get a good DR training, and there will be several of you that need to get into DR. So you want to be at a good place in case that happens. So and I fully support that will probably happen. So make sure that there's good leadership, and there's some extraneous things that programs offer, like global health opportunities, taking time off for research, taking wheel off for time off for bioengineering projects. So I think those are sometimes special depending on what applicants are looking for. So all those things, take those into account when you're looking, and you'll know the programs that you really love and a few outliers that you really don't like.
Okay, great. Dr. Cuban, just so you know, we can hear like 95% of what you're saying, but every now and then, like a word drops, or it's just a little bit fuzzy.
I'm on a landline at the hospital, so I'm not sure what else I can do about it.
Oh, that's a little bit better, actually. So we'll go ahead and move on to questions about intern year. So starting with Dr. Ingraham, what kind of intern year do you think is most beneficial for IR training? And in that same vein, are you looking for students to complete a specific type of intern year?
Yes, so in one word, surgery. So we are closely aligned with surgery. We are a technical field. I would say more than half of your consults are going to come from surgeons who should speak their language. I don't think medicine is necessarily wrong, but what I do not like to see is a transitional year spent in Hawaii hanging out, because that, to me, does not show your commitment to IR. You are entering a field that you take care of some of the sickest patients in the hospital, so you should get used to difficult patient management. You should have a good ICU background or critical care background in that internship, meaning you take care of sick patients, you help out in the ICU, or at least you're involved in sort of the transfer of care between ICU and the floor, and a good operative experience. So, you know, make sure that when you're looking at internships that you actually get to spend time in the OR as an intern and you're not just doing floor work. I think it's of great benefit to you. I'm biased because I came from surgery, but I can't tell you how well that served me. And I almost look at candidates with a little bit of scrutiny when they say, oh, I'm thinking of a transitional year. And to me, a transitional year is a little bit of a continuation of medical school. You know you're entering a technical field where you're using your hands a lot. And like I said, a lot of your consults are going to come from the surgeons, whether it's perioperative complications or ICU patients. So I would say surgery, absolutely.
Dr. Cuban.
Okay, I would say that surgery is a no-lose choice. It really speaks to me of your willingness to work hard when you don't have to. When it's your own choice, you could do a certain thing and you say, I want to take a harder path. To me, that's kind of stands on its own. You really can't go wrong with that. You're going to face a lot of the same choice when you go from DR to IR. A lot of times there's an easier way, there's an easier path. But interventional radiology is infinitely more rewarding, in my opinion, but it is a lot harder work. So that's a good way to show that you're willing to work harder for what you want to do. There are probably transitional years or medicine years that are better than some surgical experiences, that just because you may be doing some scope work. I remember when I was applying, there was a transitional year. I did a surgery year, but there was a transitional year that said I could do 6 months of surgery, 3 months of ICU, 3 months of general medicine. And I was like, oh, that sounds like a great rotation, and maybe that would be the best mix for me going forward. But it just, when you have that transitional year, unless you can really show why you're doing that, it kind of gets lost as to the other group of transitional years, which are show up at 9, leave at 3, and do kind of fluffy rotations and have an easy year. You know, there's really kind of two types of people. There's the types that brag about how much they work, and there's people that brag about how little they work. And we want the people that brag about how much they work, how many cases they got to do, how they scrubbed in, how late they stayed. We want people that are excited by those things, not that are like, oh, I got out at 2:30, it was awesome. So we really want people that work hard and are passionate, and a surgery is a no-lose choice, but there are other options. You just have to show me why they're better.
Okay, makes sense. Dr. Rochon.
Yeah, I agree with what my fellow panelists said. I actually did a medicine intern year. I would say I agree that most of our consults actually come from surgical specialties. You want to make sure that you do an intern year that you're working and you're learning. I still remember a lot of things that I learned in my intern year. Let's say you do a medicine intern year. You want to make sure that you are doing some ICU rotations. I did too. And as Dr. Ingraham said, you're going to be taking care of the sickest of the sick. You're going to be taking care of patients who are not surgical candidates. So you have to remember that. You don't want to blow off your intern year. You want to work really, really hard, because that will actually transfer, and that momentum will transfer to your IR residency. There are some programs that have the intern year, mostly surgery, linked in or kind of associated with the IR residency program. One thing that I have seen is it's really advantageous, I believe, if you can try to do your intern year where you're going to be doing your residency. One thing that I see is you start to know the system going into radiology and your IR residency. One other thing that you have, you start to grow older and go along in your residency with those surgical residents that you did an intern year with. Everyone in your hospital, so whenever you're going to get those consults, you're going to have that rapport, you're going to know and trust those consults that are actually coming in and be able to navigate the system a lot easier. Not to say I know there's going to be some type of some commitments that will keep you away from doing it at the institution, or there may not be a great intern year there. But pick a great intern year that you will excel in, you're going to be passionate with. All intern years are hard. You will work, but you want to make sure that you get the most out of it. And you can talk about it and use it as you go along in your residency.
Great, thank you guys.
Okay, so next question, we're going to be starting with Dr. Cuban. Do you have any advice for those of us who are couples matching?
I don't have a lot to add on this, except that you should really apply widely. We had quite a few people that were couples matching, and I think you just really have to focus in on areas that have a lot of training programs in both types of programs. I usually talk with them about their spouse and what specialty they're going into, and then I have reached out to other programs at certain times to kind of inquire where their other person sits on their list, and there's some things they can't quite do, so it's it's a little bit finicky what you can do, how much you can talk to, but I think it's a good thing to talk about what your spouse is going into, how competitive you think they are. If they really liked that program, someone's like, oh, someone just went to TCH and pediatrics and she really loved, or he really loved the rotation there. I like that because I'm like, okay, well maybe they're going to be happy here, the spouse is happy, then usually the other person in the mix has an easier time being happy where they are. So don't shy away from it in talking about it. If they really like the other place, that's another great thing to talk about. But otherwise, apply widely and do all the other things we've already talked about. Networking, good scores, et cetera, et cetera.
Thank you. Moving on now to Dr. Rochon.
You may find yourself limiting yourself with couples matching, but that being said, you want to apply to as many programs as possible. You want to have a conversation with your partner to see which programs would benefit both of you. But I think the number of trying to increase the number of programs that you apply to would be the best thing to do, because you are in essence limiting yourself, and it's for a specific reason. You want to make sure that those programs that you are going to be applying to, as Dr. Cuban said, trying to do an away rotation at those places, and doing well and optimizing all of your chances for matching.
Thank you. Dr. Ingraham, please.
Yeah, I don't have much more to add. It's a difficult situation. We're obviously very sensitive to it because you want to be in the same place as your significant other, and it's usually on your application, so we know. And obviously, if we really want you and want to recruit you, I will reach out to program directors from whatever the significant other is going into. But just recognize, as I'm sure you're aware, some things are out of our control. We may love you, and your spouse, peds, they may have them somewhere in the middle. So we do what we can, but it adds another layer of complexity, and you guys have to be flexible and apply to a lot of programs.
All right, thank you very much. So now we're going to be moving on to our audience-submitted questions. This is the conclusion of our set of questions. We want to extend thanks to Dr. Ingraham and Dr. Cuban and Dr. Rochon. That was very informative, and I'm sure many people will benefit from all the information that you have provided us. Now we will open the floor to questions from the audience. So just some quick instructions if you didn't catch it the first time. Please type your questions into the provided chat box and send them directly to me, Hector Bunch. And then when asking questions via the chat box, please indicate if you would like to direct the question towards an individual or to the whole group. And if you wish to ask questions to specific individuals, but you would rather contact them directly offline, you can contact them via the shared contact information. So please submit your questions now, and we will try to make this go, if time allows, until 8:30. We want to be respectful of our PD's time. We don't want to have them hostage here. Okay, so Hanan Javan asks, when you are applying for IR, your personal statement is going to be IR related. Do you think that the personal statement is going to limit your chances of getting into DR? So Dr. Rochon, could you go ahead?
Sure. You want to be honest with your personal statement. Again, it's going to show us your road to IR, your road to becoming an interventional radiologist, and you have to remember that a portion of your training is DR, and you will be we will have come out with a DR and IR certificate. Now, you do have the ability and the opportunity to have different letters of recommendation, different personal statements, and you could direct them a little bit and tweak them to where one is more IR heavy and one may not be as IR heavy, but you definitely want to make it known that you do have an interest in interventional radiology. There are going to be programs that are going to look at you and they say, hey, this person is interested in IR, and they are just they're the cream of the crop amongst all of the applicants in DR, so that's not going to look bad against you. But I would say is just be honest with yourself. Make sure that the appropriate personal statements go to the appropriate programs. But it will know. I mean, we want to see that passion that comes out of you. But just remember that you do have that diagnostic radiology component. So it is important to make that known, because everything that we do has a basis in diagnostics, and it sets you apart from other specialties.
Thank you.
Dr. Ingraham?
Yeah, I agree with Dr. Rochon. I think you should be honest about it. I don't think you should be too manipulative in how you try to present yourself, because remember, the program directors work together. The program director for diagnostic radiology is required by the ACGME to be the associate PD for the IR residency. So obviously we communicate, and it's usually pretty obvious that you're applying to DR, and I don't think you should feel bad about that. You know, they take that into account when they make the rank list. So let's be honest, they may rank you lower if they know that you're IR bound or you want to be IR bound. But I can tell you from being on the inside that at least the candidates I interviewed last year, a few of them matched into the DR program and they interviewed with IR. So you know, it's sort of what we had before as a large applicant pool just for DR. Some of you are going into IR, and if some of you match into DR, you'll get the same training. It all starts in the same place. So I think that you should be honest, and you should show your passion for IR. And you know, you may be applying to a program that doesn't have an IR residency but is very strong in diagnostic radiology, and I think that's fine. In your personal statement, you know, I think it's always helpful for me to see that you understand what DR is about in addition to IR, and you don't only care about IR. So you know, make it known that you're going into IR and that you respect DR as part of your training. I think that's the best approach.
I would agree with what the other panelists said. I would also add that I think it's probably a good idea to have two separate personal statements, and again, not be manipulative and change what you're saying, because a lot of times people communicate. But I do think that you can put a little bit of a different tone, a little bit different emphasis if you have two different ones. I think you still want to mention IR in your DR version of the letter. You still want to mention DI in the IR version, of course, but I think you can be a little bit more, your passion can shine through for IR a little bit more in the IR letter, and where in the DR letter you can, you know, say IR, but this is why I love radiology too, you know. So I think there's just a different, I think it's useful to have two different ones. They don't have to be drastically different. I don't know, I found it useful to have, I think it would be best to have two, but you could probably make it work with one. I would also limit your personal statements you know, 2 pages, some of these really long ones, you know, we try and read all of them, but we get hundreds and hundreds of applications. So a lot of times try and make them succinct. I would try and stay, you know, under a page. Don't try and push the character count on your personal statements.
Thank you. Another question from our audience is, how do you feel about Step 2 CK, and would you rather receive it earlier than later? Dr. Ingraham?
I could care less, honestly. You know, pass it. That's all I care about. You don't have to take that before applying. We've talked a little bit about step scores. If you feel your Step 1 is on the weaker side, it always helps to take Step 2 if the score goes up. But the CK, you know, in my mind, I was the first year that took it, and it really was just a requirement that had to be met. So I don't need to see that, but please pass it.
Great. Dr. Cuba?
I would say, same thing. If your Step 1 score is really strong, you don't really have a lot to gain by taking Step 2 or making sure that's available right when your application's out. And if it's not that strong, you should definitely take it and try and get a stronger score. Really, just like Chris said, you know, once you get to a certain range of scores, you're smart enough to do what you need to do, and there's a lot of other things that matter after that. But Step 2 to me is a afterthought unless you have something to prove, because your Step 1 score is low.
Great. Dr. Rochon?
I agree with Dr. Ingraham and Dr. Cuban. I have nothing more to add.
Great. Thank you very much.
Okay, next question from the audience. So for interventional radiology rotations, it can be really challenging as a student sometimes to participate and help, you know, compared to other rotations like internal medicine, where you can be much more hands-on with the patient and kind of guide their care more. So what suggestions do you guys have for students to become more involved on their IR rotations and show that they're enthusiastic and passionate? And we'll go ahead and start with
Dr. Rochon.
Okay. I kind of disagree that you can't be hands-on with your IR rotation. Remember that we are a clinical specialty, so you will be given opportunity to present your patients in rounds, to follow up on your patients. You may be working alongside a resident, a fellow, and under the attending, but you have if you know your patient really well, then just as any other house staff, we will allow you the ability to become a little bit more hands-on within the procedures. Now, even with our fellows, a lot of the attendings are more hands-on, so you have to know that. You want to be involved with the whole team. So going into the room whenever the patient's being brought into the room, helping the nurse and tech, knowing what things are going on, knowing your patient in and out, being that last person to exit the room. Whenever the attending leaves, you're still in the room helping the whole team out, unless there's some other duty that you need to attend to. But it's peri-procedural care. It's not just doing the case. That's about 20% of IR, even though this is what makes it so cool and all of us love it. But 80% is clinical and managing your patient, knowing why you're doing the case, knowing why you should not do the case, and following up with the patient. You should also want to be involved in the outpatient clinics. That's an aspect that will be required in all of IR residencies. So during those rotations, you want to know what those institutions are doing in their outpatient clinics. You may be able to rotate with other services and those IR-like rotations as well. If one of your IR patients is going into a hybrid procedure, there are so many opportunities for you to become involved and for you to shine. It's not just becoming the primary operator in the case. And I would also say the more you're involved, the more you're learning the steps in the procedure, we will note when it's ready for you to actually maybe get access, central venous access, maybe do the bread and butter things. We're going to notice those things, but you need to know your patient really well.
great answer. Makes a lot of sense. Dr. Ingraham.
Yeah, I completely agree. So being on top of the patients that you are assigned to, whether you work that out with the residents or the fellows, rounding on the patients that you've done procedures on before and after, going with the resident or fellow to consent a patient to see how they speak to the patient or their family. You know, that's really, even I have a hard time getting my fellows to do this thoroughly. That's really the hard part when you become an attending is managing your patients before and after the procedure. So yes, the technical part is the most fun, but I agree with Dr. Rochon. It's being in the room and understanding what's going on and being polite and helpful to the techs and the nurses. And also, I always tell the medical students, table etiquette, you know, understanding how the table works and how to clean wires and fill syringes, that's actually extremely important, and you can do it wrong. You can absolutely do it wrong. So don't feel like if you're just assigned to doing that or someone shows you how to do it that that's bad because you're not the one actually doing the tips or the line. There's a lot to be learned from that, and when I see you do a good job of that, I will let you try to get access or let you, you know, exchange wires and more advanced things. Now, I do care about your technical skills because it is a technical field. And I always appreciate when the med students go out of their way to ask, can I try to get access, or by the end of this rotation, can I do a line with you or something like that. I want my medical students doing that, and the visiting ones too, because I feel that you really need to show that you can understand the basic steps of some of the basic things we do. So being proactive, you know, you may rotate with a lot of different attendings, which I know is the case where we are. But going out of your way early in the rotation to ask a few of the attendings, hey, do you mind if I scrub with you? And at the end of the rotation, by the end of the rotation, would I be able to assist with a couple of procedures? I think that's absolutely appropriate, and I encourage you to do that.
I would agree with what everyone said. I would say obviously know all your patients, round on all of them, know them as well as you possibly can. Sometimes it's hard. You may not have, especially on away rotations, access as in-depth access to write preliminary notes as other people do when you're at an outside institution. But try, if you can, to write notes, to try and do some notes. And then the one thing I would add is just to really what Dr. Ingraham said about the table is like very important. So sometimes I remember when I was a medical student rotating, and I was at UCSF doing an away rotation. And I knew I was doing like a TACE or tips or something. I knew I wasn't going to really be doing the case. So I actually just started going around the other side of the table and trying to run the table like amazing. It's called the table game. So when they turned around and needed something, I already had that thing in my hand because I knew what was next. And then I think they got to understand, like, oh, this guy, not only does his table look pristine, everything's filled what I need, but when I turned around and needed contrast, because I need to confirm in the portal vein, you know, they knew exactly I knew what they needed. So I'd put it up there and they'd grab it. And I think they kind of got an idea that I knew the steps of the case. In addition to the patients, I knew the steps of the case, or at least started to learn them, and that maybe that gave them, you know, gave me a little bit more leeway to do some, you know, ports or something like that were easier things. But when you're scrubbed into bigger, complex cases with another trainee, you're probably not going to be doing anything. But you can run the table like a pro, kind of play the table game, keep everything clean, neat, and then try and anticipate potentially what they're going to need next, kind of play the table game.
Great answer. Thank you so much. Another question is, I have a PGY3 R2 DR/ESIR resident. There are currently only 16 ACGME approved independent IR residencies. Do you expect this will present a competitive bottleneck for those attempting to match into the first year 2020 of the independent IR residency from DR? Dr. Ingraham, please.
You know what? My gut instinct is don't worry too much about it. Remember, we have a lot of medical students going into IR directly from med school, so that's how most of you are probably going to get into IR, but not everybody. So the reason these other pathways have been created, ESIR, the independent pathway, is for people that make the decision later or maybe didn't match into the IR residency. I will have all three at UW, and I think my other panelists too will have some variation of that. And most big institutions that took a lot of fellows historically have all three programs. So I think that there will be fewer people doing the independent pathway, but I don't know. Maybe we'll realize that a lot of med students that match into IR might switch. I don't really know. So I think most of us that are serious about being program directors and continuing a legacy in IR have created all those pathways for all the scenarios that happen. Don't worry about it. Remember, there are a lot of places that don't have the IR residency. I know of programs around the country which are only taking a few IR residents and want to focus on the fellowship. So don't worry, just start early. If you mention to DR and you know you still want to do IR, make it known that you want to do it, get involved in your home program. If they don't have an IR fellowship or independent pathway, start reaching out early to other programs and do your work.
Great, thank you so much. Dr. Cuban?
Yeah, I also think that number is going to drastically increase. We have all three here, but in my order of priorities, IR-DR was number 1, ESIR was number 2, and just because of the date of when we start matching for them, the independent program completing the application and getting approved, it was kind of the last thing, and so we're in the process of doing that, having got the other two. So I think that number of 16 is going to drastically increase by the time you're an R3 or R4. So even though next year you'd be matching for them, I think you're going to see a lot more programs come online over the next year. Like at least double would be my guess.
Okay, thank you so much. Dr. Rochon, your thoughts?
Yeah, I agree with that. There are a lot of applications that are actually going to be reviewed next month for the independent pathway. And the APDIR, SIR, we know that we need to have these programs available for everyone, especially the R2s, for July 2020. We will try to get as many spots available for everyone. For those of you who may not have ESIR, just remember that you have the opportunity to still apply. You will do 2 years of independent pathway residency. But as my two co-panelists said, don't worry about it. We are under the gun to try and get as many programs accredited and as many spots available because we know that you're out there. We want to make sure that we have spots for you.
Thank you. So starting with Dr. Cuban, our DO peers with us tonight are wondering if you guys look at the COMLEX scores and your thoughts on those.
Look at what?
So our DO peers are wondering if you guys take a look at the COMLEX scores and your thoughts.
Yes, but I would encourage, I think most people do still take the USMLE and the steps in addition. So I don't think it's a huge, I think we're just more comfortable looking at that score in terms of comparativeness, but yes, we do look at it, but don't have as much familiarity with it.
Okay, great. Dr. Rochon?
Yeah, I feel the same way as Dr. Cuban. We're more familiar definitely with the steps. So if you have the opportunity to take the steps, that's another way that you can become more competitive. But we do look at all scores.
Great. And Dr. Ingraham?
I agree. I don't have much more to add. I'll look at them, but I encourage you to take the USMLE.
Great, thank you. Another question is, while on an away rotation, would you recommend a student to schedule a meeting with the program director or the selection committee head outside of day-to-day interactions to talk to them about their program and their application and their experiences? Dr. Rochon?
Sure, I think that's definitely a good thing to do. Note that, the program director wants to be as available as possible to talk to all visiting students. I think you should actually reach out to them and get more information. I sit down with my IR medical student rotators and talk about the IR program as well. You should be talking to the residents because remember, the residents who are going to be on the IR service are in the diagnostic program. So talking to them about the program as well, you'll be able to get a lot of information from them, and hopefully it's going to align with what the program director is going to say. But yes, definitely try to set aside some time, maybe 15-20 minutes. Make sure that you have all of your questions available and ready to ask, and that program director will be able to just put a face with the name.
Thank you so much. Dr. Ingraham, please.
Yes, I definitely encourage it. I usually make a special effort to try to meet with the medical students, all of them, halfway through the rotation and at the end, but a few are very proactive about asking early in the rotation, and I think it's absolutely appropriate. It just shows an interest in the program and that you're taking the program seriously, so absolutely.
Good to know.
Yeah, I agree. Nothing really to add. I agree, definitely.
Okay, thank you. So here's another question.
I think this will be our last question of the evening. So one of our audience members says, I have heard from some of my advisors and home program director that there is a regional bias that can exist when applicants apply to a program that is outside their region. For example, if an applicant is from the East Coast, it can be difficult to garner interviews out of the region. What is your opinion about this? And we will go ahead and start with Dr. Cuban.
Great, I have to go first on that one. All right. So I think there's definitely a lot of geographic limitations and expectations, both from the program side and applicant side. I think there are experiences that everyone has where you have certain groups of people that are, you feel in your experience of reviewing applications and interviews, may be less likely to come to your place just from where they are. I think probably other programs have the same issues as well. I would say, though, that if you really want to go somewhere, making sure that you mention in your personal statement that you are looking to potentially go out of the region, you can tailor your personal statements to wherever you're applying to for different programs. And I would say that at least having the ability to say that you're open to looking at other places is enough for me. I really don't look too much about where someone's from. I don't judge that, oh, they're from San Diego, they're not going to want to come to Houston, or they're from New York City, they're not going to want to come to Houston. I feel like I would lose a lot of great applicants if I did that. So I don't really use that as any kind of criteria. In fact, I like geographic variety in the program and the applicants. I do have some, not concerns, but I probably think at some point that maybe they'd be less likely to come. So I try to sell the city maybe a little bit more in those, or tell them about the city so they have an idea of where they're going. But I think that there's going to be programs. I feel we have a lot of things to offer that could attract people from San Diego. It's not the beach, but we have great cases, or we have great mentors, or great research. So I think both at the applicant side and the program side, having an open mind about geography is important. However, I will add that when you look at the next step after training, you're looking at potential jobs. And so this is a whole different conversation, but where you go to training does have an impact on where you'll have the most job opportunities. There are exceptions to that, especially in academics. It doesn't really apply, but usually the private practices in the region of your training program will be more highly represented by graduates of that training program. I went to a program in the Northeast at Brown. I ended up in Houston. So it doesn't always apply, but I think there's a lot of regional bias that echoes from match and then to job opportunities. So if you are looking that you definitely want to be in the Chicago area for your foreseeable future, that's where your family's from, their family's from, then maybe it makes more sense to stay in that region, or at least give programs, if there's a good fit, a little extra point for being in that region. So it's something that I think the applicants need to consider more as a program. Associate program coordinator, someone that reviews these applications a lot. It's not something that I look at as a criteria or a detractor for coming to the program. So I actually like a lot of variety and like people from different parts of the country.
Thank you so much. Dr. Rochon?
Yes, I know that there's the myth about regional bias, but we know that you, since IR residencies are really competitive, you're going to want to apply to as many as possible. Now, again, you have to be true to yourself on where you would like to end up for residency. We want to know that you're going to be happy wherever you are. So if you know that you're not going to be happy in the Rocky Mountain region, don't apply there. Don't apply anywhere that you know you're not going to be happy, because it's the waste of your time, a waste of your money, and it's a waste of the program's time. So if you know you want to be in a particular region, apply to every single program in that region, not just through IR. Apply to the DR programs there too, because that is another pathway to IR. I have a lot of Colorado students who don't particularly want to stay here. We encourage people to go other places, to experience different things, and sometimes you can bring those experiences back home or wherever region you want to reside in for a job. But as Dr. Cuban said, there are going to be some opportunities whenever you're going to be looking for jobs that you're going to be in that place for 6 or 7 years. You will have set roots there, and you may want to, spend the first part of your career there. So just be true to yourself on where you want to apply, and that's going to come through through the interview process and the application process. We do know that you're going to try to apply to a lot of programs, but sometimes it may come out that you may not want to be in that region, and sometimes interviewers can actually pick up on that. But if you're honest with yourself that you're going to be happy going to that program, I don't see a problem with it.
Great, thank you. Dr. Ingraham, your thoughts?
I don't have much to add because they covered most of it, but we certainly like what I consider geographic diversity. I'm on the West Coast. A lot of people want to be on the West Coast. I get it, or they have family here or connections in the West and they want to be here. So it's usually more of an issue for you guys if you want to live on the West Coast. But I really like seeing applicants from the Northeast or the Southeast. It's a little unusual for places like Georgia or Florida for people to apply this far away. I actually like it. I think geographic diversity matters for the program too than just having a bunch of West Coasters in our case. And the only thing I'll add is during the interview, make it known that you want to be there, but please don't just focus on that. Remember, you're there to work. You're there to find a good program. I've had some applicants, just say, I have to be here. I have to be here. My family's here, or my wife is here, or can get a job here. And yeah, that takes something into consideration for you and for us, that you're serious about being here. But remember, we're looking for good applicants and you're looking for a good program. So by all means, make sure you can tolerate the place for 5 years and don't apply to a program in a place you don't want to live, as Dr. Rochon said.
Okay, well, this is the end of our webinar. We would like to thank the program directors for taking time out of their busy schedules to answer our questions.
Thanks also to Rashad for helping us make this happen tonight. We also want to thank all of our attendees to this webinar. We hope this information has been helpful to you guys. The webinar will be uploaded onto our YouTube channel. If you're interested in reviewing this panel or any other IR information, you can refer to the SIR Medical Student Council website. And I would just like to reiterate how deeply grateful we are for the PD's time. We know how incredibly busy you guys are, and this information is so valuable to students and to applicants.
Yeah, and one last thing to add is that if you go to the website, you will find so much information that the MSC has put together for medical students, including information about the pathways, information about what makes a candidate competitive for IR, or even if you just want to brush up on techniques and procedures and clinical aspects of IR and the delivery of healthcare in IR. And well, lastly, thank you all very much. We hope you have a great night, and we hope that you have enjoyed this webinar.